I'm Dr. Charles Eaton, Executive Director of the Dupuytren Research Group. I hope you enjoy this presentation on Dupuytren disease. The point of this talk is to review Dupuytren disease concepts and impact, to review the evolution of Dupuytren research, and to discuss public advocacy for Dupuytren disease. Dupuytren is a medical condition with a variety of effects. The most visible is hand deformity with bent fingers, but it can involve areas other than the hands. It's often misdiagnosed, especially in its early stages. The most common place that people have physical changes from Dupuytren disease is the palm of the hand, and there are three categories of physical findings. The earliest show up as a nodule or a lump in the palm. People mistake these for calluses, and they often appear in places where people develop calluses in their palm. This may progress to some tightening along the length of the finger that feels like a string under the skin or stuck to the undersurface of the skin, and that's a cord. And cords may progress to tighten up and prevent the finger from being able to be straightened out all the way, called Dupuytren contracture. Physical changes are sometimes found in other areas, most commonly the backs of the knuckles, where they're called knuckle pads or Garrod pads, and in the arch or the instep of the foot, where people can develop lumps known as Lederhosen disease. The anatomy of the hand is complicated, and the anatomy of Dupuytren involvement is complicated. All of these structures may be involved with Dupuytren disease in one form or the other. And it's not simply this surface, it's a three-dimensional extent of involvement. So here's a cross-section through a cadaver hand with some of the structures that are involved with Dupuytren disease marked up in color. And you can see that the structures actually extend from the undersurface of the skin through different colored structures down to the bone. And these anchor the skin to the bone in the back of the hand. And that's important for the use of the hand because it prevents the skin from sliding around when you grip things. It anchors the skin of the palm to the hand. And this is a unique anatomy in the body that is only found in the palm and in the arch of the foot. The palm anatomy is something like a quilt. Now, when someone makes a quilt, they take a layer of cloth, fabric, and then they put on that a layer of padding, and then they put on that another layer of cloth, and then stitch through all three layers. And what this does is this anchors the layers together, and it prevents the different layers from sliding side to side relative to each other, and stitches in different areas to accentuate the contour of the cloth because it pulls down in certain areas. And this is very similar to what we find in the palm. The creases in the palm of your hand and fingers are from attachments of the undersurface of the skin down to the deeper structures. And here we have this level of anatomy, and if we look at it in a three-dimensional view, this is kind of how things are put together, and they prevent the skin from sliding around because the layers under the skin absorb the stress and strain of moving the palm around. And this varies throughout the hand, so if we go from here to just a little bit further out in the palm, we find that the anatomy changes significantly, and in this specific area we lose some of the layer that goes side to side under the skin, and that allows the fat in the palm to pooch out in areas where it's not constrained. And so when you squeeze your fingers together side to side, the skin in between the fingers pooches out. That's because it's not constrained. And in people that have early Dupuytren disease, the areas that are affected directly in front of the finger tend to retract down into the palm a little bit. And you wouldn't notice that except the adjacent areas aren't constrained. And so it makes it look as though there are bumps in between the fingers, but in fact those are just the normal areas of palm. They're called the palmar monticuli. Now here's the anatomy, just a tour going from the middle of the palm out to the fingertips. And I'll just let you watch this. These colors are the different structures that look like they're moving, but it's just because we have a moving cross section. If we're going to make progress treating Dupuytren disease, it's important that we try to figure out why people develop it in the first place. The biggest risk for developing Dupuytren disease is genetic. If you have a parent or sibling with Dupuytren disease, you have a 1 out of 4 to 1 out of 3 chance of developing the disease yourself. Not everyone with a genetic risk will develop disease. People can be carriers, and so the question is, why do some people with the gene get it and some people with the gene not ever have evidence of disease? And the answer to that is believed to be some form of trigger or some event which starts the ball rolling. And it may be a metabolic trigger, or it may be a physical trigger in the form of an injury to the hand or heavy use of the hand. The mechanism of triggering itself is not really known, but there's anecdotal evidence that that is part of the process. Dupuytren is not an event. It's a process, and it tends to progress through predictable stages, although the progression itself is not predictable. The earliest stages tend to be a lump in the palm, a nodule, and once someone has gone from a normal hand to developing a nodule, they may progress to having a cord in the hand. People with cords may progress to having the cord shrink and develop a contracture. People with contractures may decide that it's bad enough that they need to have some kind of treatment to correct the contracture, and then once the contracture has been corrected, people may go on to develop a recurrence or recontracture. Not surprisingly, for a genetic condition, the prevalence of Dupuytren disease, the percentage of a population that has disease, is influenced by the genetic background. And Dupuytren is primarily a Caucasian disorder. In the United States, it's most common in Caucasians, less common in Hispanic Americans, even less common in African Americans, and even less common in Asian Americans. Age and gender also have a significant influence on the percentage of a group that has Dupuytren disease at any one time. This is numbers calculated for the United States, broken down by age brackets on the bottom, and the percent of the population that has any evidence of Dupuytren disease, including just a nodule in the palm. Males are blue. By age 50, 1 out of 10 Caucasian men will have some evidence of Dupuytren in their palm. By age 70, that number goes up to 1 out of 4. Women lag behind because they have a delayed start, but by age 70, 1 out of 10 Caucasian women will have some evidence of Dupuytren disease in their palm, and the numbers just go up after that. The ratio of men to women with Dupuytren disease changes dramatically over time. It's not a fixed number because the relative numbers of men and women that have disease change. Because men develop it earlier, in the younger population, it's much more common in men than women, and then that ratio of men to women drops down fairly quickly and flattens out over time. Not many people in their 40s have Dupuytren disease, but in that age group, men outnumber women 30 to 1. But by age 85, that ratio is down to 1 to 1, and in part because men don't live as long as women, after age 85, it's more common in women than in men. It is as common as 5% of the entire U.S. population. That's 1 out of 20 Americans. And if you look at the at-risk demographic of people 35 and older, it goes up to about 9% of that population. That's in the same ballpark as the percentage of Americans with diabetes in that age range. Crunching these numbers across the entire U.S. population, it comes out to about 15 million Americans in the at-risk age group of 35 and older have some evidence of Dupuytren disease. Most of this group does not have bent fingers. They have what looks like early disease. About 3 million will have bent fingers, and about 750,000 will have a severe form of Dupuytren disease that tends to have a high recurrence rate after treatment, and that is referred to as diathesis. By any reckoning, it's a large number of people. Having said that, it is somewhat baffling how often Dupuytren disease is misdiagnosed or missed, particularly in early stages. People who have Dupuytren in their family are often diagnosed by a family member who has personal experience with it, but people who don't may misdiagnose it themselves as arthritis or tendinitis, and unfortunately, people who have their first diagnosis made not by a family member but by a physician will have seen more than 2 doctors for the condition before they get an accurate diagnosis. And this is even more baffling because the condition is diagnosed only by look and feel. Currently, there's no unique test, there's no blood test you do for it. If it looks like Dupuytren, that's what the diagnosis is. Dupuytren has significant personal impact on the function of the hands, on social issues, and on the person's overall health. People with Dupuytren disease describe a variety of things in which it interferes with their life. These are just some of the things that have been reported on surveys of Dupuytren disease, and not all of these have to do with bent fingers. There are poorly defined issues that people have with Dupuytren disease that involve pain and stiffness, fatigue of the hand that are difficult to describe. And if you look at these, there's nothing which is life-threatening, but it cuts across everything that someone does during their normal daily life. And because of that, some people will describe it in much simpler terms as saying that it's disabling because it affects their life in many, many ways. It's difficult to describe, so people can't easily explain to someone the kinds of trouble they're having, but that doesn't make it any less legitimate. In social situations, the only part of someone else that you see on a regular basis is their face and their hands. And we use our hands actively when we meet a new person. We shake their hand. And because of that, someone who has a visible deformity or difficulty with using their hand because of Dupuytren disease, and because it's difficult to describe, meeting someone, shaking their hand for the first time turns that into an ordeal rather than the natural social interaction that it should be. And this is not a small issue either in personal life or in business. Dupuytren also has health effects beyond just having a bent finger. Failed Dupuytren surgery is the most common reason for people to have a non-emergency finger amputation, an elective finger amputation. That's scheduling to have a finger amputated, not for trauma. And that alone is an index of how far we have to go with developing better treatment options for Dupuytren disease. That is the definition of failure of treatment, when people with a benign disease have to make a decision as to whether or not they want to have their finger cut off as being better than the finger that they're currently living with. Beyond that, Dupuytren affects overall health. People with bent fingers from Dupuytren disease have, on the average, a shorter life expectancy for a variety of reasons. They have an increased cancer risk with a variety of cancers, and the reasons for this are not known. But they point to the fact that Dupuytren is not just bent fingers, it's a systemic medical condition that affects many parts of people's biology. Part of the puzzle of Dupuytren disease is that it's like an egg with two yolks. It's got two different things going on. It has a biologic aspect and it has an anatomic aspect. And these run in parallel but don't overlap that much. The biology needs biologic treatment. We have none currently. We do have anatomic treatment, which has been what surgeons have been doing for the last 200 years. Biology is the risk factor for developing a nodule in the first place, or from progressing from a nodule to cord, or from progressing from a cord to a contracture. Biology doesn't really affect the chance of having a straight finger from having a bent finger treated, but it does affect the risk of having recontracture or recurrence after treatment. Anatomy and procedures really only impact part of the Dupuytren process, and that is that the procedure that's done and the technical aspects of the procedure and the technical aspects of the anatomic changes that take place impact the risk and likelihood of going from a bent finger to a straight finger with treatment, and additionally impact the risk of going from a straight finger to a recontracture. So both of these things are going on at the same time. Currently, the only thing that surgeons have to offer is in the area of this red arrow, and only partly impacts the risk of going from a straight finger back down to a rebent finger. There are two types of procedures that surgeons offer to correct the deformity of Dupuytren contracture. There's open surgery, which is the most commonly performed treatment of Dupuytren contracture, and the most common operation here is fasciectomy. Fasciectomy is opening up the palm, going down into the palm and taking out the diseased tissue, which allows the finger to straighten out. There's an extended version of fasciectomy called a dermofasciectomy, which includes a fasciectomy but also involves removing some of the affected skin and replacing it with a skin graft. And dermofasciectomy is done primarily to try to influence the risk of having a recontracture. it doesn't get the finger any straighter than a traditional fasciectomy would. The other types of procedures are minimally invasive treatments, and these have in common the fact that no tissue is actually removed. The tight tissue under the skin is either weakened or cut, and the fingers pulled on to separate the tight string under the skin to allow the finger to be straightened out. The comparison of these is that the open surgery lasts longer on average before contractures return. That's the big selling point for it. Minimally invasive treatments have a much faster recovery, lower complication rate, and if someone has a recontracture, repeat procedures are much more safe in comparison to open surgery. Physicians make a decision about what type of procedure they're going to recommend based on how bent the finger is and what their soft estimate on how biologically aggressive the individual's Dupuytren disease is. And this ranges from minimally invasive to fasciectomy with some technical variations to try to get the finger straighter, to more aggressive procedures. And if you look at the columns on the left and the right, the difference between the two is on the right side, the procedures are more radical, and the idea behind that is that by doing bigger operations, the person may have a longer period of control before their contractures recur. That difference is trying to treat the biology of Dupuytren disease with surgery, not to try to get the finger straighter than it otherwise would be. Long-term outcomes also depend significantly on what the person's biology is. So if someone has a mild biology and a mild bend in their finger, they really have pretty good odds of having a good long-term result. Even if they have a severe bend in their fingers, surgeons have developed a number of fairly sophisticated technical approaches to deal with severe contractures, and the long-term outcome just based on contracture is still fairly good. If someone has severe biology, however, regardless of their contracture, their odds of having a good long-term outcome and not having multiple procedures is not as good. And this is an exposure of the difficulty that we have trying to control a medical condition with a surgical procedure. So what do I mean by good outcome or bad outcome? It's actually surprisingly difficult to describe. We have a couple measures of outcome. One is whether or not someone gets a straight finger and then loses some degree of correction, or whether someone needs to have a retreatment. So that's a measure of outcome. The other is what the angle on their finger is. So we have a protractor, we can measure how bent a finger is, and that gives us what you'd think would be very precise data, but in fact all of that's just a small portion of the effect of treatment on Dupuytren disease, because it doesn't reflect how it impacts people's lives and pain and stiffness and awkwardness of use independent of the degree of bend. In fact, if someone has a bent finger and they have surgery and they get that finger straightened out, the protractor will say that's a great result. But if the person loses the ability to make a fist because of complications of surgery, that patient would disagree that that's a good outcome. More importantly, we don't have any kind of measure of biologic outcome. We don't have a way to tell, have we really affected the biology or not? This leads to difficulty in recommending the best treatment. This is a patient of mine I saw years ago who had fairly severe contractures on both hands, and the traditional treatment for this would be to do fasciectomies on each hand, and because he had such severe disease, to think about, at least on the left hand, a dermal fasciectomy to reduce his chance of having a recurrence. He didn't want anything to do with that. He came to me to have a minimally invasive treatment, and I performed a needle aponeurotomy on him. And 13 years later, with no additional treatment, he looks great. This is great for him, but this is due to luck. This doesn't mean that he had a great procedure. That doesn't mean that he had a great surgeon. What this actually means is that I didn't have a good way to assess what his biology was. I thought he would do much worse than this with the procedure that I performed. And fortunately, he was stubborn, because he dodged having 2 big operations and upwards of a year of recovery and complications and all of that. Uncertainty is big problem with treatment guidelines for Dupuytren disease today. Ideally, we match the treatment to the biology. And if we don't do that, we risk undertreating patients and doing a procedure which is not going to work and giving people false hope, and then having them have to be treated again unexpectedly. Or we do a big operation and subject the person to the risk of complications and long recovery without any added benefit. And this is something which happens on a daily basis with people with Dupuytren contracture, and the patients live with the consequences of the inability of surgeons to accurately measure their biology. Now, before we can really understand the biology, it'd be a good idea to try to pigeonhole Dupuytren into what type of disease it actually is. Just looking through this list, this is one of many different ways to categorize all disease. And looking at this, well, there are some inflammatory characteristics of Dupuytren, and part of the biology that's involved in repairing wounds is also active in it. There's no evidence that it's a circulation problem or a blood clotting factor. There are some genetic aspects to it. The immune system is involved in ways that still are not well characterized. It's not a cancer. It's not a neoplasia. It's not a benign tumor that's growing independently just on its own. It is a reactive process that is more of a response to a trigger than an independent growth. There's no evidence that it's an infection. There's no evidence that it's due to environmental influences or nutritional deficiencies. It's not a disease of children. But it is a disease of aging, and it is a disease to the extent that the palm of the hand acts like an organ. It's a disease of organs. So this is a lot of territory, and it doesn't pigeonhole easily, and that's one of the reasons that it's difficult to describe Dupuytren disease, because you can't just say, oh, it's an infection, or even, oh, it's genetic, even though it is. Diseases of this nature are diseases which represent problems with systems biology, with how multiple systems in the body interact with each other. Systems biology research is replacing the type of biologic research that had been going on fairly steadily for the last 100 years of trying to drill down to what is the cause of a disease, what is the one factor that started the disease. If we can identify that and treat that, then we will turn the whole process off by turning off the spigot at its source. And that kind of logic really stems back to the treatment of infectious disease. When people had infections and it was figured out that there was one medicine you could give that would fix that infection, that led people to try to treat all diseases that way. But our biology is far more complicated than that. The systems biology is embracing the concept that some diseases are not one problem, but they are the perfect storm, or the tipping point, or the interaction between the seed and the soil. It's an issue of relationships, and the way that systems biology works is to combine many different categories of data into one data source, and then use a variety of methods to develop models of the relationships between the different types of data to come up with a model of disease. Dupuytren clearly falls into this. So this is a representation of a microscopic view of Dupuytren tissue. So we have cells, we have proteins, we have the matrix, which is the glue that holds all the cells together in your tissues. We have mechanical forces, and we have collagen strands, and all of these things are in the same picture. And what research has been doing for decades on Dupuytren disease is similar to saying, oh, that purple cell, I bet that's it. I wonder if that's the problem. Let's learn everything about that purple cell, and that may lead us to the one thing that is the source of Dupuytren disease. Or let's look at that protein. Maybe if we understand that, we can unravel the whole thing from this single starting point. But in fact, it doesn't work that way. There is no one source. That's why this looks similar to a traffic jam. You can study any one car as much as you want, know every nut and bolt in the car. You can study the asphalt, you can study the marks on the asphalt, and you're not going to get a good picture of why this traffic jam developed. And so in a similar way, we need to look at the big picture of Dupuytren disease, and we need to do that with a systems approach, which is different than how Dupuytren has been studied in the past. Dupuytren is not the same in everyone. It's probably not just one disease. It's very likely not just one cause, and there probably is not going to be just one solution. We have to apply current biologic research tools to this old problem. Here's the current way that Dupuytren disease is triaged and treated. Someone is diagnosed with Dupuytren disease and is at the stage they just have a nodule or a cord, they don't have a bent finger. They can choose to ignore it, or they can choose to treat it with a number of options that, because there's not a good way to measure long-term outcomes of Dupuytren disease, it's hard to quantify how effective these potentially preventive treatments are. And ultimately it doesn't matter, because once someone has a diagnosis, the next step is to wait. Generally, treatment is not considered until somebody has a contracture of more than 20 degrees of a joint. Surgeons don't get involved until that point, and if someone doesn't have much of a bend, they can safely ignore it and wait and see. But if someone does develop a contracture more than 20 degrees, then they have to decide, well, is this something that I'm going to ignore, or will I have some kind of procedure to try to straighten this finger out? And if they do decide to have a procedure, then that closes the loop. There's no off-ramp to this roadmap, because we currently don't have a procedure that cures Dupuytren disease. After treatment, the person with Dupuytren disease still has Dupuytren disease, and they are back on the route of waiting to see if they develop a contracture in the treated finger or in an untreated finger. In this respect, Dupuytren is like a car that needs brakes. We need something to slow down and stop the progression of disease. If you wanted to get brakes for your car, if you wanted to compare which brakes are the best to see which ones work and which ones don't, the tool that you'd need to have for that is a speedometer. If you really wanted to do it accurately, you'd have to be able to measure how fast you're going and measure what happens when you put on the brakes. But we don't have a speedometer for Dupuytren disease. Really, all we have is the equivalent of an odometer, which is how bent fingers are, and that tells you how far your Dupuytren has gone. It doesn't tell you how fast you're going right now. Speedometers and odometers are ways that we measure the health of a car, and biologically those kinds of things would be called biomarkers. Biomarkers are measures of disease and health and the effects of disease on health. There are three common types of biomarkers that relate to Dupuytren disease: trait, state, and rate. A trait biomarker is your lifetime risk of developing a disease, and the common example of a trait biomarker is DNA. Your DNA doesn't tell you whether you have a disease or not. It really just tells you what's on the menu for your life. It doesn't tell you what's actually going to be served. A state biomarker is an index of how much change a disease has caused. And in Dupuytren disease, this would be our protractor. And that tells us how much of a bend has happened in the finger. It doesn't tell us whether the finger is bending right now. It just tells us what has happened up to this point. A rate biomarker would tell us what is going on right now, what our current risk is for developing future changes. So we need a better measure of Dupuytren disease. We need a Dupuytren rate biomarker panel. This is important to predict long-term outcomes, to guide treatment so that people can have the treatment matched to the disease, and most importantly, to allow the development of testing of preventative treatments for Dupuytren disease. You can't test a medicine for Dupuytren disease if you can't measure its effect in some kind of quantitative way, particularly if you're going to develop a preventive treatment. Now, developing preventive treatments for chronic diseases is a common, well-established process that is normally done by medical doctors who treat chronic progressive diseases. And the process is you develop a measurement of the disease, you treat the disease with whatever your treatment is, you wait for that treatment to have its effect, and then you remeasure your measurement. Currently, we only have a mechanical measurement. We only have our protractor. So the way that we would apply this is, if we wanted to test a medicine, we would get a measurement of how bent the finger is. We'd give the medicine. Because Dupuytren progresses very slowly, we'd really have to give the medicine for years, and then we would remeasure the finger. Then we would have to guess whether any changes or lack of change in the finger was due to the effect of the medicine. And that kind of research is not going to get done because no funder would fund research that had as many difficulties in interpretation and took so long to do. What we really need is a biologic measurement, similar to treatment of your cholesterol. If your cholesterol is high, you can have some kind of intervention for that, diet, exercise, lifestyle changes, and then remeasure your cholesterol. And the cholesterol becomes a proxy for your risk for having a heart attack or stroke. You don't have to wait to see if you have a heart attack or stroke. You can just follow the cholesterol. And this greatly speeds up the ability to test whether or not medicines work or don't work. And for Dupuytren disease, this would fit right in. We get a measurement, biomarker panel measurement. We can give a treatment and then remeasure the biomarker after a short period of time to see if it had any effect on the core biology as a proxy for having to wait for measurements of whether or not fingers have bent or not. So the strategy to find a cure starts with the search for biomarkers. Once we have biomarkers, we can identify molecular targets for drugs to act, and then we can use biomarkers to test whether or not the drugs that we think might work actually do work. The key step is finding the biomarkers. This is the core activity of the Dupuytren Research Group through our International Dupuytren Databank. And the databank is set up primarily to find biomarkers. We're gathering additional information as well, but the way it works is fairly straightforward. We have online surveys that people can self-report medical history and Dupuytren-related data, and we can stratify our enrollees based on their self-reported data of degree of contracture and risk factors for recurrence. Once we reach our funding and enrollment benchmarks, then in these different groups we can test blood specimens on the different groups and see what the difference is in our biomarkers between people that have severe disease, mild disease, and no Dupuytren disease. There's a long list of candidate biomarkers. Most of these are available only in blood. We can measure DNA in saliva, but that saliva doesn't give us everything that we need to look at this point. It'll be important to look both at DNA and these different markers to do a systems approach and to develop a growing database of additional information so that at some point in the future we may be able to drill down to the DNA and stop the process more effectively. A study like this has to be large by design to get the right type of information. DNA data, because it's very complicated and because Dupuytren is a common genetic problem, we need a very large sample size, at least 10,000 samples of DNA from people who have disease and a similar number from people who don't have disease. That's the entry-level size of sample that we need for DNA. Fortunately, DNA is not that expensive to study, but with a large number of people, the budget runs up. We also need to look at a variety of blood biomarkers, and these are simpler things to assay if we wanted to measure transforming growth factor beta or other growth factors. We get a single answer on that rather than the very complex data we get from DNA analysis. So we don't need a large sample size of this, and that's good. On the other hand, biomarkers tend to be more expensive to study than DNA, and so even though the sample size is smaller, it's still a fairly expensive endeavor. And our entry-level budget for this type of data is in the range of $5 to $7 million. And in pharmaceutical research, that's an extremely low budget, but that's what needs to be done to begin the process of testing what medicines might work. The future of Dupuytren is going to be different than it is now, and here's a possible scenario. Someone may notice a nodule or a cord, or want to have a definitive answer on what the lump is in their palm, or they may have a family history of Dupuytren disease, or they may get suggestive data from retail DNA genotyping service such as Ancestry.com or 23andMe. All of those things would drive someone to see their rheumatologist, their medical doctor, who would perform the initial evaluation. And the initial evaluation would be to get a biomarker panel survey to assay, do they have active Dupuytren biology now? And if they do, then they could go on preventive treatment that would be guided by biomarker results over the long term. If they don't, then they could still have a DNA panel to see their lifetime risk, and if they have a suggestion that they are at risk, they could have their biomarkers monitored longitudinally over time, and if they become abnormal, they could be treated. That all happens in the rheumatologist's office, and only after that is the question come up of, do they have a deformity? If they don't have a deformity, then that's great. They can continue on their medical management. If they do have a deformity, then the surgeon would be consulted, and the point of consulting the surgeon would be to provide the simplest, safest option to correct the deformity. It would not be to ask the surgeon to do a radical procedure to try to cure the biology with a surgical procedure. It would be to try to get the patient better quickly. And this is the type of model that exists in hand surgery for a variety of rheumatologic conditions, that they are managed by the rheumatologist, and the surgeon only steps in like a SWAT mission to take care of anatomic problems that have developed and need to be corrected. And this is the model in rheumatoid arthritis, in Raynaud's disease, in gout, and a variety of other rheumatologic chronic diseases. Our goal is to minimize the lifetime risk of suffering and complications from Dupuytren disease and its treatment. And we can do this. This will start with awareness. One of the biggest problems that faces Dupuytren disease research is lack of general awareness, both in the public and in the medical sector. We need to raise awareness to improve our ability to have research funding, and also to recruit patients to participate in research. Once we have all of these done, then we can proceed with research using a systems biology approach to develop the type of treatment breakthrough that has been eluding doctors for hundreds of years. One of the key challenges to making progress with research toward a cure is lack of public awareness. It's an uphill battle. Dupuytren is a strange word to English speakers. It's hard to pronounce. It's hard to spell. It doesn't rhyme with anything. People may hear it and have it just go in one ear and out the other because they don't recognize it. I've had people recommend that we change the name of Dupuytren disease to something that's more recognizable, to bent finger disease, or to the name of a famous person who had Dupuytren disease, such as Ronald Reagan disease, or Frank Sinatra disease, or Margaret Thatcher disease. But that's really not the problem. The problem is that people aren't talking about it. There are a number of medical conditions that have weird names that you know about because of advocacy. You know about Alzheimer's disease. You know about Parkinson's disease. You know about epilepsy. And you know about these because there have been public awareness campaigns to try to get the word out and get people familiar with those unusual words. In some ways, having an unusual name is an advantage, because if you say Dupuytren disease, there's no question what you're talking about because it's a unique word. The key thing is to talk about it at home, at work, with friends, and say the word over and over again so that people hear it enough that they will recognize it over time. Dupuytren, 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 Dupuytren. Beyond that, it's important that people realize it's a real problem. And it's good to get people's attention with facts about Dupuytren disease which are dramatic and are real. Dupuytren cripples hands. There are as many as 15 million affected Americans. Current treatment is inadequate for a portion of people with Dupuytren disease. Some people wind up having their fingers off because of Dupuytren disease and our inability to provide adequate treatment. It's very helpful in awareness campaigns to have a personal aspect to Dupuytren disease. So if you have Dupuytren disease, be vocal about it. Tell people, I have Dupuytren disease. If someone has Dupuytren disease, it's important that they know that it's a family condition. Even if they don't know anybody in their family with it, they need to know that their children, their grandchildren could have Dupuytren disease, and it could be worse than their Dupuytren disease. Our goal is a cure in our lifetime. We're all working together for this same goal. If you're a social media person, put the word out on social media. Tweet, post. There's an active Facebook group, the Dupuytren Disease Support Group. Talk to all of your doctors. Bring them Dupuytren brochures. If you have government contacts, contact them. Centers for Disease Control website, the CDC, their webpage does not have the word Dupuytren on the website. There are no Dupuytren-specific NIH grants that are currently available. That's got to change. This is a common problem. It has significant health impacts and it affects millions of Americans, and there's no medical treatment for it. That has got to change. The Dupuytren Research Group is the only group that's doing this kind of research. You can get facts about Dupuytren disease by texting DupFacts to 51555. You can go to our website on your phone, text Dup to 51555, and get the information that you need to participate in the effort to find a cure for this disease. Thanks very much for watching.